PhysioEx is first. You will be doing spirometry today. And remember, when you do your spirometry, you are the blower, you are not the sucker. Do not inhale, you exhale only. If you inhale, you will aspirate a lot of water, and you don't want to do that. In activity 1, we were doing spirometry to measure volumes and capacities, and that's exactly what you're going to do today. On the static spirometers, you're going to find out your tidal volume, your ERV, your IRV, your vital capacity, all of these things. And I want you to know that when you actually start to do that lab, all of your volumes and capacities are going to be off the charts. I mean, out of normal range. Because when you start thinking about how you breathe, you don't breathe how you normally breathe. And some of the simple math calculations that you're going to do tonight, when you actually start using your data, oh good, we were running low. Just put it, yeah, trust me, it's amazing how this will go. Anyway, you're going to get some negative results, and remember I said that you have license to change your data so that you at least get numbers that are near what you should get. You can't have a negative lung volume. You can't have a negative lung capacity. That is nonsensical. So adjust it as necessary. There are normal values. There's 2 sheets of white paper over here on that counter, and then in the back there are 2 tables in blue back there. Those show you normal values for individuals matched to your age, your height, and your gender identity. And those charts were made years ago, so there were only 2 gender identities back then. So pick one that is closest to what you identify with, okay? Huh?
What if the one that I'm closest to is not?
Then have someone do this for you. That one.
Just a question. Who's above?
Yeah. Yes. Anyway, so on chart 1, there's a lot of data that's there in front of you. And I would like you to look at the following columns. Please look at radius. Please look at flow. Excuse me. Thank you. And please look at FEV1. Those are the ones that I want us to look at that changed when we changed the radius the most. We started out with a radius of 5, and then we progressively got smaller to 3. I'll remind you with Poissonier's law that as we have a smaller radius for our airways, we're going to have an increase in resistance. And if we have an increase in resistance, it is going to be tougher to get airflow through the lungs. So notice as the radius went down, so did our flow. And also notice that the FEV1, which is the second to the last column, also decreased. FEV1 stands for forced expiratory volume in the first second. And tonight, before I set you off for you to do your labs, I will show you how to calculate your FEV1 over FVC. FVC stands for forced vital capacity. And again, we'll be using the tracings in the lab manual tonight for the dynamic spirometry. Are there any questions regarding that experiment? Nope. Well, if you did, you're going to have a lot more answers, if you do have questions, when you actually do those labs on your own person tonight. And not all of you need to do your own lung volumes and capacities. If you just want to designate one person per group, that's fine as well. It's just kind of fun to do your own lung volumes. But that's up to you. How many of you thought playing with your own pee was fun? Yeah, see, I'm that way too. But not all of you share my enthusiasm in that regard. In chart 2, experiment 2, we had a normal person, we had a patient with emphysema, We had Prince Harry that had an asthma attack. We had, no one did it, did you? Did you not notice the people that were hooked up to the spirometer? The person who had an asthma attack, I mean, how stereotypical can they get? Redheaded person with freckles. Did no one notice that? And it was also creepy that they blinked as the experiment went on. So right now I know who did it and who didn't.
So blatantly obvious, I simply understand.
That's why when I said Prince Harry had an asthma attack, you all were like.
I have no idea.
Then we had the same person with the asthma attack have their inhaler. And on a separate issue, we did 2 experiments where we had moderate exercise and heavy exercise. Now, the people with breathing problems are in a totally different conversation than when we started to exercise. So let's address the people with the breathing disorders first, and then we will come and address the exercise. So for the breathing disorders, please look at forced vital capacity, FVC. Please look at their FEV1 and their FEV1%. FEV1% is calculated by dividing your FEV1 by FVC. So if you see FEV1% in your lab manual tonight, please understand it's a ratio between how much air you could blow out in the first second versus how much air you could forcibly exhale, going from a maximum inhale to a maximum exhale. So let's look at those columns. We had the normal person, their forced vital capacity was 5 liters. And they got an FEV1% of 80%. Remember, all of us should be 80% or better by getting 80%. That means 80% of your air out in the first second of exhale. And then the patient with emphysema, notice that the amount of air they can forcibly breathe out was almost reached, well, it wasn't quite in half, but it was 3,250 milliliters. So it was drastically cut down compared to 5 liters. And their FEV1% was down to about 50%. That is a diagnostic test that says this person has an obstructive disorder. That is what we use to diagnose an obstructive disorder. If this FEV1% is less than 80%, it's obstructive. Then we had a patient with an asthma attack, and again, their FEV1% dropped below 80 significantly. It was cut in half. Then when the person used their inhaler, it helped improve matters. Now, there is a very annoying question that I want you to look at in the review sheets. And it was number 6 on page 114. And it says, how much of an increase in FEV1 do you think is required for it to be considered significantly improved by the medication? And the medication that they're referring to here is the albuterol, which would stimulate the beta-2 receptors and lead to smooth muscle relaxation, which would reduce the resistance by increasing the radius of the air passageways. That's a silly question to ask. How much of an increase do you think is required for it to be considered significantly improved? I can tell you this. Ask anyone who's ever had an asthma attack and ask them how they feel after taking a puff on their inhaler. They're going to feel a lot better. I mean, we want them to get back to an FEV1% of 80%. That tells us that their air passageways have improved to the point where they're now back toward normal. So that's our answer. We want them to hit that 80% mark. Are there any questions on that one? No? Okay, well then let's focus on the moderate exercise and heavy exercise. With the moderate exercise and heavy exercise, please look at the normal row for ERV and IRV and tidal volume. So the first 3 columns, please look at the first 3 columns for the normal patient. Then look at the first 3 columns for the moderate exercise and heavy exercise. Again, that's tidal volume, ERV, and IRV. Do any of you exercise? Good. What do you notice about your breathing rate and depth when you exercise? Goes up. So that means your tidal volume goes up. If your tidal volume goes up, then what do you think is going to happen on either side of it for your inspiratory reserve volume and your expiratory reserve volume? What will happen to your reserves? It'll go down, of course. So if you need more money to pay your bills at the end of the month and you tap into your savings, how much of your savings will you have? You're going to have less, aren't you? So think of the reserves as your savings. If you are breathing bigger breaths, deeper breaths, you're tapping into your reserves on the inspiratory side and expiratory side. So notice with the exercise people, their tidal volumes grew, which we would expect, and their reserve volumes reduced. Does that make sense? Okay, good. Then the last activity for the respiratory was we were playing with the role of surfactant and intrapleural pressure when it comes to ventilation. Just to remind you from Unit 4 from 2 weeks ago now, when we talk about the work of breathing, surfactant lack is under the restrictive category, which means it's difficult to inhale. All of your alveoli, to refer to an analogy that I used 2 weeks ago, all of your alveoli are lined with mucous membranes, which means there's just a thin layer of water. And when you exhale, your alveoli have a tendency to collapse. And we learned about Laplace's law and which sized alveoli are more prone to collapsing. On your next breath in, you need to oppose the surface tension of water. You see, surface tension around your lung in the pleural cavity with the pleural fluid is good. We talked about that. That was the suction cup. You want to get it wet, it sticks to the wall of your shower. Surface tension, water surface tension in your lungs is a bad thing. Then that means you have to peel open the millions of alveoli that you have. Surfactant reduces the surface tension. When it comes to your lungs being compliant and opening up, I'll remind you, only 1/3 of their compliance to be stretched open is from elastic tissue. 2/3 comes from the surfactant. We started out with no surfactant inside the lungs, and then we went up to 2, and then we went up to 4 units of surfactant. The intrapleural pressures in the left and right lungs were negative. Intrapleural pressure is always supposed to be negative, and during your inhalation, it can become even more negative. So when we had our negative intrapleural pressures and we had a surfactant that went from 0 to 2 to 4, please notice the last column, our total airflow improved significantly. Then we went back to our baseline where we had no surfactant. We got our original value in row number 1. And then we caused a collapsed lung in the left lung. Now, I don't know about you, but when I did this experiment at first, I actually clicked on the left lung. And the computer said, nope, please click on the valve controlling the left lung. And I did. And I did. And I did. Isn't it the patient's left? PhysioEx clearly does not know the difference between the anatomical position versus someone sitting at a computer. Anyway, they wanted your left, which would have been the patient's right. Anyway, when I finally caused that collapsed lung, please notice that the intrapleural pressure in the left lung dropped to 0, which means there was no difference between the intrapleural pressure underneath the rib cage versus out here in the atmosphere. No difference. That's why it was 0. And when we did that, our airflow was cut in half. The other lung was unaffected, but the collapsed lung could not handle any airflow because we need an intrapleural gradient that's negative. After 2 attempts, we then sealed that damaged valve. It was supposed to represent a wound. And our last experiment, we got back to our original values. Airflow was restored. Are there any questions on that? Okay, well then. Please turn to your acid base. And there were 4 activities that I asked you to do. None of these activities for the respiratory nor the acid base should have taken you very long. It's kind of nice to end on some PhysioExes that were short and sweet for once. But in activity 1, we looked at hyperventilation. Hyperventilation means our respiratory rate and depth is higher than what our metabolic needs are. So we're over ventilating. That's different than hyperpnea. Remember hyperpnea. With hyperpnea, we're breathing more, but our metabolic rate demands that, like if you were exercising. But hyperventilation, you're just excessively ventilating and your tissues don't necessarily need that. So we hyperventilated, and as we did that, our pH rose. It went from about 7.39 up to about 7.68. It reflects us blowing out too much CO2, which we should know from our Henderson-Hasselbalch equation that is our acid. If we lose our acid, our blood pH will go up. And then what did we do after that? We clicked normal breathing after that. Did your breathing in your little demonstration actually go back to normal right away? No, it did not.
I was just testing it.
No, it did not. Actually, what happened was there was no ventilation for a while. This represented the lungs, quote, trapping, the respiratory system trapping CO2 to help lower the pH back down toward normal. Then normal ventilation ensued. But it did not return to normal right away, and that was the right thing to show you. CO2, I'll remind you, is the #1 gas that controls your ventilation rate and depth. And it indirectly stimulates the central chemoreceptors through the hydrogen ion receptors. So they showed you the right thing by showing you ventilation decreasing before you actually saw normal ventilation return. Are there any questions to that one? Okay. Then in activity 2, they also showed you something spot on. And if you didn't catch it, you really should at least go back and just watch 20 seconds of this experiment. It wasn't a long experiment, but they showed you a lot of stuff going on that was perfect. First, we had normal breathing, and then we had rebreathing. And you should have noticed that when we clicked rebreathing, and that's very similar to someone breathing into a paper bag, right? Especially if they're hysterical. They are rebreathing the exhaled CO2 right back into their system. We should recognize that as them rebreathing the very acid they're trying to get rid of. If I rebreathe acid, my pH is going to go down. If my pCO2 levels in my blood go up beyond 45 millimeters of mercury, just going up to 48 millimeters of mercury, my ventilation rate and depth can go up 2 to 3-fold. And if you watch the video for that experiment, as the rebreathing is occurring, you see the balloons that represent the lungs starting to expand and recoil with greater volume and frequency. So ventilation rate and depth were going up as the rebreathing was occurring. Any questions on that one? Okay. Activity 3, renal responses to respiratory acidosis and respiratory alkalosis. Well, let me just do a quick run through. If it is a respiratory disorder, CO2 is the issue. If it is a respiratory disorder, the respiratory system cannot compensate. In the case of acidosis, we will see the renal system compensating in 2 different places. The first place will be in the proximal convoluted tubule. This is where any of the filtered bicarbonate can now be reabsorbed. If we are in acidosis, we don't want the current bicarbonate we have to go on to the toilet. How does the PCT reclaim the filtered bicarbonate? Inside the cuboidal cells, CO2 and water are reacted using carbonic anhydrase to form carbonic acid, which dissociates into bicarbonate and hydrogen. That bicarbonate goes to the blood. The hydrogen is secreted through a hydrogen-sodium antiporter. The hydrogen that is secreted into the filtrate will combine with the bicarbonate that has been filtered to reform carbonic acid, which dissociates into bicarbonate which dissociates into, in that reaction, that way, CO2 and water. CO2 can go on its way to the toilet, or it could go right back into the cell to be used again in that reaction. Any water is going to go to the toilet. The bicarbonate that was filtered is now chemically changed. The bicarbonate that we made inside the cell goes into the bloodstream. So we've lost the filtered one, but gained one inside the cells. This is not a net gain nor loss. They offset each other. In the late distal convolute tubules, specifically in the alpha intercalated cells, the same reaction occurs, except the hydrogen is now secreted through a hydrogen ATPase. And the hydrogen that's secreted no longer binds to bicarbonate that's in the filtrate because the PCT already took that back. Now the hydrogen that is secreted needs to bind to some other buffer, either the phosphate buffers or the ammonia buffers. With alkalosis, none of these steps would occur because carbonic anhydrase is exquisitely impaired with high pH. We learned from Unit 2 that enzymes in our body work at an optimal pH. For carbonic anhydrase, a high pH reduces its activity. And that's good, because if we already have a high pH, we do not want to reabsorb our filtered bicarbonate, and we certainly don't want to make more. Again, the late distal convoluted tubule is where we would have a net gain, a net synthesis of bicarbonate by the alpha intercalated cells. We would not want that in alkalosis. Does that make sense? Okay. Then the last activity was the respiratory response to metabolic acidosis and metabolic alkalosis. Before I talk about the data, let me remind you, when it's metabolic, both renal and respiratory systems will compensate. Yes, they will. So all of the renal compensation that I just discussed would again occur for metabolic acidosis in the case of the PCT and the late distal convoluted tubule handling the bicarb. And in the case of metabolic alkalosis, the carbonic anhydrase would again be impaired. If there is renal compensation, the urine will reflect the problem that the body has. If the kidneys are helping with acidosis, the urine will become acidic. If it's alkalosis, the urine will become alkaline. A reason why PhysioEx focused on the respiratory system for this activity is because the respiratory system is the fastest to respond. But please remember, it's not the only system to respond to metabolic disorders. So if it is metabolic acidosis, you should have seen that the ventilation rate and depth would have increased, trying to blow out the extra CO2. Losing the acid would have helped raise the pH. In metabolic alkalosis, you should have seen ventilation rate and depth decrease, trapping CO2. Trapping more acid means we are reducing the pH back down toward normal. Are you okay with that? Yes? Okay. Well then,